So without further ado, we'll jump into our presentation this evening. Why am I not getting pregnant? There's my social media. Admittedly, I'm not too active on that, so you can email me if you want, violet.klenov@kindbody.com. So here we are at Kindbody. We have a mission to improve access to fertility care. It's really a right and not a privilege. So we're working hard to make sure that everybody has access to get the care that they need to be able to start and add to their families. What do? We provide fertility services, counseling, support. Fertility services run the gamut. So for men, women, transgender individuals, we perform IUI, we do IVF, we do fertility preservation, we provide information in the form of genetic testing, both preconceptually and of embryos. And we do offer generalist gynecological care as well in some of our regions, and then provide in-depth counseling and adjuvant services to help overall fertility health and general health with nutrition and mental health and centers of excellence in all of these areas. So Fertility 101. What do we need to get pregnant? So it's really as simple as this. We need to have eggs, we need to be regularly releasing them, we need to have healthy motile sperm, and we need to have a normal uterine environment free of things that could get in the way anatomically of getting and staying pregnant. And we need open, healthy fallopian tubes. Fertilization actually occurs in the fallopian tubes, and egg and sperm have to meet that way. So let's start at the beginning. Women are born with all the eggs that they're ever going to have, and that's about 2 million. By the time that you interesting point is you actually had the most eggs you ever had when you were a 20-week fetus, and then the slow and inevitable decline in egg reserve actually starts before you're born, such that at the time of birth you're already down to about 2 million eggs. And then by the time you start your first period, what we call menarche, you're actually already down to about 300 or 400,000 eggs total. And then you lose eggs all the way through menopause. And it's not like you just lose that one egg that you ovulate. You still lose eggs even if you're on birth control pill, IUD, you're preventing pregnancy. And you lose much more than that 1 or 2 eggs. You lose many, many eggs each month, which is part of the reason that decline can be a real deal, and the average age of menopause in this country is about 51. What happens to ovarian reserve? So what even is ovarian reserve? It's how we screen to see how many eggs you have left. Best ways to do this, we'll talk about later, are usually with blood tests, specifically a blood test for AMH or anti-Mullerian hormone. And that gives us an estimate of how many are left. It's not like it tells me exactly how many eggs you have, but it tells me, are you normal, low, or above average for your age? We screen in other ways too, like your antral follicle count, which is an internal ultrasound measurement of how many eggs you start with at the beginning of a cycle. But this is a nice depiction of your egg reserve over time. So again, around the age of a woman's first period, which back in the day was 13, it's closer to 8 or 9 in this country lately. And then egg reserve continues to decline all the way through the age of average menopause, which is age 51, at which point those eggs are just not doing much for you, and therefore most women stop having regular menstrual cycles at all. Menopause is when you don't have a period for a full year. This other line reviews your monthly birth rate, or your chance for getting and staying pregnant each month when you have unprotected intercourse without fertility issues. That peaks at around 20% when you're young, and then it'll decline over time, primarily as a result of reduced egg quality as well as reduced egg numbers. But important point is that having a low egg reserve does not mean you're infertile. Plenty of women walk around with a low egg reserve and get pregnant all the time. The key is that you got to be regularly ovulating. And if you are infertile, like you've spent a year of trying to get pregnant and you have low egg reserve, then there is a problem. Or you have irregular cycles and you have low egg reserve. But if you just go out and get your egg reserve tested and you're low and you haven't even yet tried to conceive, there's no reason to think you're going to have trouble just because you have a low egg reserve. I hope that makes sense. So you might have heard or been frightened by the age 35 in terms of that's what's called, geriatric pregnancy, or what happens to your eggs? Do they all shrivel up? And they really don't. There's nothing magic about 35. It's just a nice cutoff point for us in the medical profession to talk about increased risk for certain things happening. The inflection in that graph in terms of the rate of egg loss, it just accelerates a bit at age 35, if you can see. But there's truly nothing magic about age 35. And when we talk about something like freezing eggs, you want to do that at an age where there's plenty of eggs and those eggs are healthy. And generally, we think about doing that less than 35. Some people advocate even less than 30 if you can, but there's nothing magic about 35. You're waiting till 36, 37, you haven't met the right partner, etc. Again, nothing magic there. And sometimes women actually have a low egg reserve far below the age of 35. So this reviews a little bit more about the egg quality in addition to egg quantity. So women are born with all the eggs they ever get, but the double whammy is that the older we are, not only do egg numbers decline, but quality declines substantially as well, which can increase the risk of difficulty getting and, more importantly, then staying pregnant, because those eggs, if you think about it, you've had them since you were a fetus. They've been with you, arrested in meiosis, which is the process of the egg dividing its DNA. Because if you think each cell in your body has 46 chromosomes, so an egg, in order to then create a unique individual, is actually what we call haploid. So those cells that are 46, they split, and so it's got to be 23 and 23 to combine your egg with the sperm of choice in order to make a unique embryo or unique individual. And the older that you are, that egg that is arrested in the process of splitting its DNA, however old you are, 35 years, 40 years, the machinery that is used for that egg to split DNA equally to result in an egg that's 23 and 23, it doesn't work as well. And so there are increased errors. And so maybe you get an extra chromosome 21, and then that egg contributes to a Down syndrome pregnancy. Those errors, they go up the older that you get. So for those of you just starting your journey of trying to get pregnant, when are you most fertile? So if you have a regular cycle, what is a regular cycle? Like anywhere 21 to 35 days in between periods is considered regular or normal. Now, most women are going to land closer to about 28 to 30 days. And most women are fertile or are ovulating mid-cycle. So if it's a 28-day cycle, most women will be getting a positive on their ovulation predictor kit around cycle day 13, 14, 15, 16. So we say the fertile window is really the 5 days leading up to ovulation, as well as the day of ovulation. Sperm can live in the reproductive tract for 5 days. It's wild. There have been studies done back in the day where women would have intercourse, and then women, like at the time of laparoscopy, 4 or 5 days later, you could actually sample the fluid in their abdomen and find moving sperm. So the key is to get sperm on board prior to ovulation, because that fragile egg can only survive for 24 hours. So the sperm has to be present ideally before you ovulate. And remember, when you're doing a urine ovulation predictor kit, you're testing for a hormone called LH, and that LH surge actually predates you releasing an egg, because that's the signal from the brain to the ovaries to say, okay, great, pop that follicle, release the egg. So you're going to ovulate probably the next day after you get a positive on your OPK. So the best days to have intercourse are the day you get a positive and the next day. Some people aren't really into tracking ovulation. Some guys get stressed out, have performance anxiety. If that's your situation, just have maybe intercourse 2 or 3 times per week. It doesn't have to be every day. And again, it can be stressful, and it's important to maintain the health of your relationship. And guys, although they don't have to do too much work when it comes to this, can be quite sensitive, and they can have a hard time when you say, today's the day, do it. So what do we learn when we screen your egg reserve tests? These are the tests that I reviewed. Your AMH hormone, generally a normal result for an AMH is like 1 to 3. As you're closer to that 1 side, I start worrying a little bit. Are you on the lower end? Please remember that if you're on a long-term birth control pill, that can falsely lower your AMH. And so if it is low and you're on a long-term contraceptive like a birth control pill, usually I'll say, let's repeat it. Maybe not wait on doing something to preserve fertility, but that may be the reason it is on the lower side and not truly because you have diminished ovarian reserve. The antral follicle count is that ultrasound measurement of how many eggs you start that month with. That can vary month to month by a couple, maybe 2 to 5. But if you're starting with 5, it's unlikely that next month you're going to have 20. It's usually within a pretty tight range. And again, this tells us only about quantity of eggs. Overwhelmingly, the best predictor of egg quality is your age, female age. Now, there's other reasons women struggle to get pregnant. So I encourage all of you out there, if you are not having a regular menstrual cycle, if you know that your partner has a history of, let's say, testicular surgery, injury, undescended testicle as a child, some scar in his lower pelvis that he doesn't remember what it's from, move more quickly to get fertility evaluation testing. Please do not spend a year trying to get pregnant if you can't even figure out when your last period was, because that really suggests to me that you're probably not regularly ovulating. So don't waste a year of your life doing that. So these are the conditions that make it harder to regularly grow and release an egg. Polycystic ovarian syndrome, issues with your thyroid gland or prolactin hormone, what we call hypo or hypothalamic dysfunction, where your brain isn't sending signals to your ovaries to grow and recruit an egg, possibly a result of low body mass index or low body fat, due to body dysmorphic issues, anorexia, bulimia, and some other causes for this as well, which your REI can fully investigate if we have concerns, or the worst situation where you have run out of eggs prematurely, and that is why you're no longer regularly ovulating. How do we evaluate the lining of the uterus? There's several different ways to do so. What we standardly do and offer is a test called a saline ultrasound. And how we do that is we put in a speculum in the vagina, pass a small catheter through the opening of the cervix. The uterus is a closed space, so what we do when we put water in is we open it, and that allows us a glimpse at the lining of the uterus in a really sensitive way to allow us to see if there's anything in there contributing to difficulty getting or staying pregnant. So what we're looking for is there a polyp? Are there fibroids? Is the uterus a different shape? Is there something called a uterine septum? Is there scar tissue? And then at the end of that test that we do in my office, we're able to take a look to see if tubes are open on both sides by putting some bubbles in the fluid or a special foam that highlights the fallopian tubes for us to say, are tubes open and healthy as well? There's other ways to take a look at uterus and fallopian tubes. Another way to do that is an HSG test, or the hysterosalpingogram, commonly referred to as a dye test. That's the one where they put X-ray dye in your uterus, done much the same way as a saline, tends to be a little bit more crampy, and then you got to get an X-ray. That test isn't quite as sensitive for finding issues with the lining of the uterus, but it is excellent for fallopian tubes. Hysteroscopy is actually a procedure where we put a camera into the uterus, usually when you're asleep under anesthesia, and then take a good look at the inside of the uterus directly. It's kind of the gold standard, and sometimes we'll go straight to that if you're at high risk for a uterine problem, or we have a high enough suspicion that you just do that first ahead of treatment. Endometriosis is a common gynecological condition. A lot of our patients with infertility have endometriosis. And what that condition is the lining of the uterus that usually is responsive to your hormones, and then you result in a period if you're not pregnant. That tissue that responds, grows, sheds, actually gets out into the pelvis, likely by extrusion through the fallopian tubes, and gets stuck places that it shouldn't, such as your bowel, the lining of the abdomen, your ovaries, sometimes even up into the liver. In rare cases, it even goes through the blood and ends up in people's lung in the most severe cases. This condition can be very painful. It can be asymptomatic. The amount of disease in the pelvis isn't always correlated to the amount of symptoms a woman may have. So sometimes we do a laparoscopy procedure for another reason. Maybe the woman needs her appendix out and they note severe stage endometriosis, but she is asymptomatic. Or we only have a couple lesions and that woman has severe pain during her period. Primarily, women with endometriosis present with bad pain during their period. And it is associated with endometriosis because it can increase the risk of scarring of fallopian tubes. It can reduce egg quality, probably because it's so inflammatory. And then more and more, we think maybe it has a role to play in the uterine receptivity arena, or does it affect the lining of the uterus and the ability to get pregnant? And this is another slide looking at the abnormal shapes and configurations of the uterus, which are related to difficulty conceiving or increased risk of miscarriage in certain instances. So this is a septate uterus. I always describe it as like a widow's peak to the top of your uterus. This should not be there. It should be flat or just a mild heart shape. A mild heart shape is called an arcuate uterus. It's a variant of normal. And what a septate uterus is where this widow's peak goes down more than a centimeter. If it goes down more than a centimeter as measured by a skilled sonographer, then I'd recommend you remove that because there's decent association with infertility as well as increased risk for miscarriage with a septate uterus. Asherman syndrome is a condition where there's scarring inside the uterus, most often the result of a uterine procedure, like a DNC. The most common culprit is like you had a baby, maybe you're struggling with secondary infertility, but following your first delivery, you had to have a DNC because a bit of the placenta got left over, something like that, or there's been an infection in the uterus. Bicornuate uterus is anomaly of the uterine development where the top of the uterus actually dips down into this cleft area. This is not surgically correctable and is associated with increased risk for certain bad outcomes. And all of these things we can diagnose on the saline ultrasound. Okay, and don't forget the partners, for those of you who have them, who have a male partner who wants to use his sperm. It's a little bit archaic. We make women do a lot more. So men, I always make this joke, they get off easy because what they do is they just bring us a semen analysis. We poke them for some required blood work. This field is emerging. We're learning more and more about how to evaluate sperm health and like the male fertility side of things, but it's still in its infancy. So we use a semen analysis to see, do you have enough volume? How is the count? Ideally, it should be, 15 million per milliliter or greater. We want to see a good progressive motility as well as total motility. And then morphology is the size and shape of sperm under the microscope. I don't get too excited if the only abnormality is a low morphology when count and motility are totally normal. Keep in mind, we want to get this test done ideally when their last ejaculation was within 2 to 5 days, rather than like too little of an interval in between or too long. And couples a lot of times will ask, well, is it better for a guy to ejaculate more frequently or save it up, so to speak? And generally more frequent ejaculation is going to be better, primarily for the morphology or the health of that sperm. So don't wait, 10 days and just save it to have intercourse the day of a positive ovulation test. Probably better for guys to ejaculate frequently. All right. Other factors impact fertility, clearly, and we continue to learn. This field is fascinating. And so things that are in your control somewhat in terms of navigating this journey, depending on where you're at, are the things that you are eating, the chemicals you are ingesting, chemicals you're putting on your body and that you're exposing yourself to. So consistently, the styles of eating that are associated with improved pregnancy rates, either naturally or with treatment, are things like Mediterranean style lifestyle diet, whole food, plant-based diet. Supplements is such a hot topic. Everybody wants a pill that's going to make things work. At the end of the day, it's like everything else. There's no magic pill. What is going to help you is effort in terms of getting to a healthy weight if you're not there, and then clean eating, whichever style of eating you want, doing your best to minimize preservatives in your food, getting your food from a local source, specifically meat if you're going to be eating meat. Fresh and local, high in whole grains, legumes, fruits, and vegetables. In terms of supplements, prenatal vitamin, and then depending on the specific condition that you're up against, PCOS has a slew of different vitamins. We might recommend some prescriptions. Diminished ovarian reserve may focus more on antioxidants. But again, getting those macro and micronutrients from food sources is far superior than going out and spending a ton of money on supplements that may not even impact your chance for success. Family history is important. We always gather that when I'm seeing you for a first patient visit. And then mental health. Infertility sucks. If you're experiencing that, then I'm very sorry. Your mental health and wellness is a priority as you go through this, because when patients drop out of fertility treatment, most people think it's because fertility treatment's too expensive. It's too difficult to navigate with a busy work schedule, but it's not. At the end of the day, what we lose patients leave treatment because it is emotionally exhausting, and it is a roller coaster. So getting your systems in place to help you cope with the difficulties and inevitable lack of predictability. And for most of you, if you're anything like me, a lack of control. So type A people do not do well by being told, we just got to see what happens. And you do the same thing each time and you might get a different result. So that lack of control is challenging. So getting your systems in place to be able to tolerate that is important. Is it meditation? Is it yoga? Is it cognitive behavioral therapy? Is it acupuncture? Whatever you need to get those things kind of locked in ahead of starting this process, and or if you're struggling already in navigating that, like why isn't it happening? It can lead to a lot of stress and anxiety and cause challenges within your relationship if you're in a relationship. So what can you do? Come see us. You feel like you want to educate yourself. You feel like you're at a point in time where it's not happening for you. You want to move forward, or you're in that group where you're not regularly ovulating, or you have some concern for male factor infertility. Don't hesitate. You really got nothing to lose. We will meet with you, review your history, give you specific recommendations based on your individual data and results. Go through the checklist of how is everything looking? What things can you be doing to optimize? And then make a personalized plan for you, be it continued trying on your own. I have a lot of patients who want as little stuff done possible. They want to get pregnant as naturally as they can, but they've struggled. So then how do we kind of allow them to take that into treatment, understanding that their priority is to be a little bit more hands-off? Surprisingly, we can actually do that even when we do IVF, which seems like this big, aggressive medical thing. There's ways that we can make it feel more natural and make you feel like you're still able to do things in the way that you initially wanted. So yeah, that roller coaster. So you've got options. We've got different tools in our arsenal to help you conceive in whichever way that looks, be it with the use of donor sperm, donor egg, gestational carrier, reciprocal IVF, whatever you need. Here are the locations of all of our clinics throughout the country. We're continuing to grow and provide improved access to care across the country. Here's how you schedule, and I'll allow some time for some questions. All right, looks like our chat group, we got people in New York, California, Arkansas, yay, Georgia, Illinois, California. Anything jump out? Anybody? Washington State, love it. Good, we've got clinics near you guys. Somebody has a diagnosis of PCOS. Is FSH an indication of egg quality? It's like the other ovarian reserve screen. So when you check an FSH, it should be checked on cycle day 3, 4, or 5 at the beginning of the cycle, because really you're looking to see what it is in relation to an estradiol level. Checking a random cycle FSH is not helpful. And when we check it, ideally we see it be less than 10 to suggest there's a healthy egg balance. Because again, what you're looking for when you check an FSH is how strong are the signals from the brain to the ovaries. And the older you get, the fewer eggs that you get. The brain, if you can imagine, it starts kind of shout. Before it would just whisper with the FSH. It would just say, grow an egg, grow an egg. The FSH would be nice and low, and the ovaries would hear that whisper. The older you are, the fewer eggs that you get. The ovaries aren't very responsive because there's not many eggs. So then the brain starts shouting, and the FSH goes high, 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 high. And when you're in menopause, that FSH is like 50, 75, 100. Interestingly, some of the infertility medications that we use back in the day were made from menopausal women's urine. It's where Menopur was actually originally made, because the FSH levels were so high. But to answer your question, the FSH is not necessarily, you can't, still age is the overwhelming best predictor of egg quality, and FSH doesn't really reflect quality, it reflects quantity. All right, next question. Does shape of sperm, the morphology, impact fertility? Is only the normal shaped sperm able to create an embryo? Generally, yes, it's the normal shaped sperm that have what it takes to be able to bypass the vagina, bypass the cervix, bypass the uterus, and meet an egg in the fallopian tube. The ones with 2 tails or 2 heads just spin themselves in circles and really never get there. So again, that's why I say if the morphology is low, I'm generally okay with that. I'll still tell guys to get healthier, take supplements, etc. Because if there's still a healthy concentration and healthy motility, that low morphology is kind of overcome by the fact that there's tons and tons of sperm. Now, if concentration and motility are low, then you're working with fewer sperm to start with and a higher percentage of abnormal sperm, then you may have a problem. My cycles have generally been about 40 days long following a miscarriage a few months ago. I'm sorry you went through that. How long should I wait before seeking fertility treatment? I think that depends on your age. If you're older, and how long you had been trying prior to getting pregnant. And it can take some time for a menstrual cycle to normalize following a miscarriage, but usually I'd expect within 3 months of your loss to get back to what you were before. And if that's not happening, then absolutely seek care. Or if you just kind of want to educate yourself before trying again, miscarriages can be traumatic. Been trying for 3 years, and I had 1 failed embryo transfer. I found out I was positive for ureaplasma. Have you seen this affect fertility? So positive for ureaplasma and looking at, let's say, chronic endometriosis, I'm going to assume maybe this was tested from like an endometrial biopsy or like a vaginal swab. And the thinking there is if you're colonized with a bacteria, does that reduce the chance for success? It's a little bit debated in our field. There's some small studies that suggest bacterial presence either in the vagina or in the uterus may be associated with increased risk for miscarriage or recurrent implantation failure. Again, not solid like class A data. So I would say if you just failed 1 embryo transfer and you were found to have ureaplasma, there may be an association, but it's hard to say, did that cause the failure? Most of the time, that was just not your embryo and you got to try again. I'd still treat the ureaplasma, but hard to say, was this the reason for the failed transfer? Most of the time it's still up to the embryo to do what it needs to do. What are instances where FSH could be falsely suppressed? So being like on a recent birth control pill or checking FSH if you're on some kind of hormonal supplementation such as a birth control pill or recent exposure to it can suppress FSH and give us a falsely reassuring one. Participants been trying to conceive for a year. Ovulation is regular. HSG looks good. What could affect my fertility? So this brings to light a kind of frustrating diagnosis called unexplained infertility. I think the only other more frustrating thing is secondary unexplained infertility. But unexplained infertility is when all the tests that we just reviewed, egg reserve screening, uterus, tubes, semen analysis, other hormones that can impact ovulation, they're all normal. So why the heck isn't it happening? 85% of couples should have gotten and had a baby within a year of unprotected intercourse. And when we do all the testing, we find that you have unexplained infertility. There's some excellent treatment options, but it's very frustrating. So to this participant who's saying she's ovulating regularly, her tubes are open, likely her uterus is normal, I'd make sure your partner has had a semen analysis. So first and foremost, I'd finish the evaluation. And then if you have unexplained infertility, really treatment options are two: oral ovulation boosting medicine, Clomid or letrozole, plus an insemination. I would not do either of those things alone for unexplained infertility, since they don't boost your chances significantly at all, or IVF, depending on your age and egg reserve. Next participant, are there specific types of older women who get pregnant naturally? Are they very fit? Man, I wish. I have a lot of patients and friends who are like the most fit, healthy people, and they struggle. And it is, again, it's age. It is age. So the most healthy 42-year-old woman, triathlete, very low body fat, nothing but healthy plant-based diet, is going to do worse than an obese 25-year-old woman who smokes. She truly will, and it is not fair. It is all dependent on age, almost all. But certainly you're going to help yourself if you are healthy, you've taken care of yourself, you eat well, you exercise, you do all the things that you want me to do, or that you want to do. And the women who get pregnant naturally who are older, honestly, I think that they, for the most part, get lucky. It's not like they have higher quality eggs than women who are older who don't. They just found that one good egg a little bit more quickly. So the key is, if you have a healthy egg quantity, you have more eggs to select from and a higher chance of finding that healthy egg. IVF can be helpful for you to find that healthy egg because you get much more than one egg per cycle. Next participant, I'm 36 years old. So is the age affecting? 36 is still a good age to be trying to conceive. More and more across the country, women are delaying childbearing. 36 is not old. 36 is a great age to be starting a family. The impact of age is real, but 36 is good. It's a different story, I think, if you are significantly, over the age of 40. 36 is a totally fine age, but I'd encourage you to not wait a full year. After the age of 35, infertility is diagnosed as 6 months of trying to get pregnant and not having luck, whereas less than 35, it's 12 months. So I would start the evaluation process sooner if you're older than 35. Next participant, what would I recommend for someone whose cycle is 21 days? I've gone through 3 at-home inseminations, 1 medicated IUI, and haven't gotten pregnant. I'm 31. So the age is great. So egg quality is on your side. With intermenstrual intervals, like truly from the cycle day 1 to the next month's cycle day 1 is only 21 days. It's a little bit on the short side. So my concern would be, do you have a healthy egg reserve? I'd make sure that you get the egg reserve screens to help you plan your treatment, because if egg reserve screens are healthy, you want to be a little bit more hands-off. You might try some of these less conservative treatments longer, but if you find that egg reserve values are lower, you might move forward more quickly with a treatment to expedite your chance for success, because you're not going to have all the time in the world. Because again, egg reserve doesn't predict fertility, but it does predict your responsiveness to treatment and success with something like IVF. What is the success rate for IVF with patients diagnosed with endometriosis stage 4? Endometriosis is a tough one because endometriosis patients, fully transparent, they have a worse prognosis than patients with any other fertility diagnosis in terms of the egg quality issues. Now, it's still quite good, but compared to other women who have PCOS or their issue is a tubal problem, we think patients with endometriosis don't do quite as well. So the chances for success with endometriosis stage 4 depends on how many eggs you have, because the chance for success with IVF is dependent on egg reserve and your age. So if you are young and you have a healthy egg reserve, I think your chances for success are still very good. They're not as good as somebody with another diagnosis, but they are still excellent. And if you are young and with a healthy egg reserve, chance for a baby with each embryo transfer is going to be 50 to 65%. But endometriosis is challenging. Next patient, I had a recent pregnancy with anencephaly. Oh, I'm so sorry. Would you suggest genetic screening? Not all anencephaly is genetic. So it's possible that that might have happened even if it was a genetically screened and euploid embryo. I'd be curious if you had genetic testing for that pregnancy loss to see if there was a genetic anomaly noted with that anencephaly. I can tell you your doctor in the next pregnancy is going to have you be on a much higher dose of folic acid. I have a bad experience with a reproductive doctor. Does Kindbody have a recommended clinic in Washington? Yes, we have a clinic in Vancouver, Washington area. We were only told our option was IVF simply because we are over 40. Any thoughts? So my approach with patients is always patient-centered. So I will present you with the options for treatment, and then you steer the ship. So after the age of 40, depending on your diagnosis, your best chance for success is probably going to be IVF. I can tell you that with full certainty if your diagnosis is unexplained infertility, primarily because of the reduced egg quality in terms of your age. So there's a nice study that was published in Fertility and Sterility, actually called the 40 trial, FORTY, aptly named, and it looked at women who were 40 who were hoping to get pregnant with unexplained infertility, and half of them did like IUI cycles and half went straight to IVF, and the ones that went straight to IVF got pregnant more quickly and cheaply as compared to wasting time and money on a less successful treatment. But again, it's individualized. So I'm here to present you statistics and options. And then I think I very strongly take into your value system and priorities for moving forward. Next participant, I'm 28 years old and have been diagnosed with PCOS. I've been trying to conceive for 5 years now. Recently moved to a new state and found a doctor who told me they could not give me ovulation medication because they wanted me to lose weight, and I will conceive naturally. Okay, again, kind of like a one-sided. I think again, it's a holistic approach. Myself, all doctors want you to be as healthy as you can before you get pregnant. If you are young and your egg reserve is healthy, and you might decide, hey, I want to get healthier before I get pregnant, but it's not a one size fits all. PCOS makes it harder to lose weight. It makes it harder to sustain weight loss. It's much harder as compared to a woman without PCOS to do those things. So you got to focus on efforts that kind of help work with your altered metabolism because of the PCOS. And every clinic has different policies for that. But again, I think you got to take the whole patient in mind, and you might have been just working your butt off to lose weight. You just can't get there because of the PCOS or because of the stress associated with things. I'm also quite candid and say, depending on your body mass index, why don't you consider bariatric surgery? Now that stinks because you have to delay getting pregnant for a year after, but the key is not just getting to a baby. The key is making sure you're around for that baby. And the best thing you can do is be as healthy as you can before, during, and after pregnancy. All right. Can having high testosterone levels in females cause infertility or issues with conception? So depending on how high, that may warrant additional investigation, such as ultrasounds of your ovaries. A lot of times an elevated testosterone is associated with polycystic ovarian syndrome. So it all kind of depends on the rest of your picture. Are you regularly ovulating? How high is it? I would discuss that further with your doctor. And then another question, what age should we stop trying with our own eggs and look into using a donor? Again, I think this is individualized per patient. So I have older patients who are able to continue trying with their own eggs because they have a high egg quantity. And I also have younger patients who have to stop treatment using their own eggs because they have diminished ovarian reserve or primary ovarian failure. So no matter how much they try or how good their insurance coverage is, they just can't get more than like 1 or 2 eggs each cycle. And even though the quality is good, they just can't get there numerically. So sometimes young patients have to consider a donor, whereas older patients are able to keep trying. So again, I think this is individualized depending on your age, your egg reserve, and the outcome that you get when you're able to hopefully undergo a transfer. So, and not a one size fits all, but generally it's quite hard when you're, nearing 45 and you're not cycling, there's hardly any eggs present. because then it's a big double whammy in terms of egg quantity and egg quality. Next question, I found out through a thrombophilia blood workup that I have an MTHFR mutation. How is this approached and treated prior and during pregnancy? I was told it is prone to blood clots in the first trimester, which causes miscarriage. How does one treat the MTHFR? So this is to be honest, like a little bit of a pet peeve of mine. So I'd be curious why this was tested for you. Did you have recurrent miscarriages, or was it just tested randomly? This is a very common genetic mutation, is not always associated with increased risk for badness, especially if you only have one bad copy. That said, because of some small increased risk associations, primarily with miscarriage, we usually just have patients take a higher dose of either folic acid or taking methyl tetrahydrofolate. I would review this with the person who ordered the test for you and see what they recommend you take moving forward to potentially reduce the risk of those bad things happening. Can controlled Hashimoto's, medicated in range, still have an effect on fertility? Unfortunately, yes. So there's some recent data looking at women who have like TPO antibodies or autoimmunity against the thyroid, commonly seen in Hashimoto's. And even if you get the TSH in a perfect range, the fact that you have those TPO antibodies still does put you at increased risk for miscarriage. Now, it's better to have it under control, but probably there is something to that autoimmunity, and primarily that increased risk is in miscarriage, not getting pregnant. And still the risk for miscarriage is quite low, but higher than a person who doesn't have that autoimmunity. I found out, okay, good. We got the MTHFR. Okay, perfect. Okay, last question here. I'm 46 with high blood pressure on 2 medications and I'm overweight. At this age, what would be my best option? Again, it's an individualized counseling and I don't have enough data to tell you point blank, which is the best option. I'd recommend you visit with a reproductive endocrinologist and quickly, if time is of the essence, time is of the essence, if you are interested in exploring using your own eggs, but I can tell you it's going to be challenging. Well, thank you guys so much. What a pleasure it's been. Kind of funny to just have heard myself talk this whole time. Hopefully this was useful and helpful. Please reach out anytime, and don't forget to fill out that survey that we'll be sending. Let me know if there's anything I can be doing differently or better, or that we can.